Welcome to this January 16th, 2024 webinar recording from California Department of Healthcare Services, facilitated by WestEd. In this video, all information conveyed visually is spoken by the presenters. Thus, this video's content is accessible for users who are blind or visually impaired.
Thank you so much for joining today's workshop. We're really glad you're here. Today's workshop will be here to provide you with LEA BOP support, how to start and participate in a billing consortium. And I know many of you are already familiar with this, but if you're not, and as a reminder, LEA BOP stands for Local Educational Agency Medi-Cal Billing Option Program. Next slide. We are going to get started with some introductions. So we're going to start with introducing the LEA BOP Operations and Department of Healthcare Services team. From DHCS, we have Sarah Burkowski, Lydia Outland, Stephanie McGee, and Regina Zern. And then from the WestEd team, we have Jeremy Ford, myself, Lisa Eisenberg, Lisa Morris, Colleen Meacham, and Malachi McCormick. And then I'm really excited to welcome our guest speaker today, who's Debbie Connor from the Mendocino County Office of Education. Next slide. This workshop is part of DHCS's effort to increase understanding about the LEA BOP and improve program participation among LEAs. While not all LEAs do, some find the program to be administratively burdensome. There are a variety of strategies that LEAs can use to address and mitigate that burden. And then given some of the administrative requirements for participating in LEA BOP, today's workshop will cover one of those strategies for how LEAs can collaborate together to share some of those administrative responsibilities. So the goals for today's webinar are for participants to, 1, understand the responsibilities and timeline of LEA BOP administrative responsibilities. 2, to understand the benefits and considerations of joining a consortium. And then the third goal is to understand the purpose of a billing consortium and requirements for leading or participating in a consortium. Next slide. Here's our agenda for today. We will begin with an introduction and refresher on the LEA Billing Option Program and cover some of the administrative requirements for program participation. Then we will move on to discussing some of the consortium requirements and structure. Then, as I mentioned already, we're really lucky to have Debbie Connor from Mendocino County Office of Education joining us today to provide a real-world example of a consortium in practice. We will follow that with time for questions and answers. Yes, agree, Debbie is a rock star. And then finally, we will close out today's session with some next steps that you can take. We want to encourage you to use the chat field to submit questions throughout the workshop. We have individuals monitoring and noting the questions submitted via chat, and we'll either respond to those during today's training or in writing after today. And then presentation slides, a couple questions already. Presentation slides and a recording of today's workshop will be posted on DHCS's website in the future. And participants in today's webinar will be notified via email when those are available online. Next slide. So this section of today's webinar will provide an overview of LEA BOP's administrative requirements. Next slide. For many of you, this is a refresher, but some of the key things to know about the LEA Billing Option Program are, 1, it's an optional program to recoup some expenses for providing covered health services for students enrolled in Medi-Cal. And that 2, LEA BOP is an ongoing funding stream. LEA BOP is a billing and reimbursement program to generate funds for the costs your LEA incurs to deliver covered services. Next slide. Previous workshops which many are posted online already, but previous workshops provided a much more detailed overview of the payment cycle and how the funding mechanisms and timing work for the LEA BOP program. The graphic on your slide is a simplified overview of that process, which I will walk through from left to right on the graphic. So first, LEAs deliver services through allowable practitioners employed or contracted with the LEA. Then LEAs submit claims to Medi-Cal for covered services, and then LEAs receive interim reimbursements for those allowable services throughout the school year. Then LEAs reconcile actual costs with those interim reimbursements, and this is through the cost report that is submitted 8 months after the end of the state fiscal year. Then those actual costs are audited to verify that they are allowable expenditures. And finally, the process concludes with a final audited payment within 18 months. I know those are a lot of steps and with lots of complexity, many of them requiring administrative capacity and backbone support for LEAs to participate. And to contextualize for today's workshop topic, it's important to note that a billing consortium, which we will describe shortly, can help LEAs with almost all of the payment cycle and process, noted by the orange bracket on the bottom of the graphic. Next slide. So to set the stage for how billing consortia can be beneficial, we want to first review the administrative requirements for LEA BOP participation. So this is not specific to a billing consortium, but on your slide, you see a representation of how LEAs participate in the program without being in a billing consortium. So as you can note on the slide, each LEA provider has a direct relationship with the Department of Healthcare Services, DHCS, represented by the dotted lines between each LEA and DHCS. And each LEA is responsible for all of the administrative requirements listed in the boxes below each LEA. And I'll walk through those as a quick refresher and explain what some of those administrative requirements are. So first, the Cost Reimbursement Comparison Schedule, or CRCS. This is the annual cost report that I mentioned previously that participating LEAs are required to submit that certifies the cost of providing LEA BOP covered services to students. Second, you have the Random Moment Time Survey, or RMTS. This is a statistically valid time study mechanism that California uses to determine the amount of time spent on activities throughout a participant's workday. The administrative component for RMTS is ensuring all eligible practitioners are on the Time Survey Participant, or TSP list. Sorry, excuse me. We did a workshop in October about this, and those slides are posted online. We're dropping a link in the chat to the slides from that past workshop. Another administrative component of RMTS is ensuring that practitioners are responding to the moments that they receive. The third administrative requirement is the annual report. This is different from the CRCS. The annual report provides DHCS with the most up-to-date contact information and program participation changes. And then the fourth administrative requirement is that there are day-to-day claiming and service documentation requirements, including submitting interim claims for treatments and assessments, ensuring that services provided to students are thoroughly documented, ensuring that practitioners are appropriately licensed and or credentialed, and reviewing the electronic health record system or whatever system your LEA uses for documentation to make sure that practitioners are complying with documenting their services. I know that's a lot of information. I really want to emphasize that the main takeaway from this information is that these are some of the administrative responsibilities that can act as a barrier for some LEAs to participate in LEA BOP, even just walking through them, it sounds like a lot. So it's a lot for an LEA to take on in some cases. And these are some of the administrative requirements that can also be mitigated by participating in LEA BOP through a consortium, which we will describe very soon. Next slide, which we will actually describe right now. I will turn it over to my colleague Jeremy, who will walk through a little bit more information about a billing consortium.
Hey, thank you, Lisa. Now let's talk about consortium requirements and structure. Next slide, please. Okay, so what is a consortium, right? In this graphic, you'll see the member LEA interacts with the lead LEA, and the lead LEA is the one turning in the paperwork to DHCS. In the previous slide, we mentioned the administrative requirements, and on this slide, we break down where those kind of fall. So we'll be going into more details over the next few slides, but if you look at this graphic, you can think of items like day-to-day claiming, service documentation, following up on moments, and those things between the LEAs flowing to the lead LEA. For the connection from the lead LEA to DHCS, that's going to be items like the CRCS that we mentioned before, the RMTS, the annual report, and again, day-to-day claiming and service documentation. That's everyone's responsibilities. But before I go into the details of the requirements, let me get into some of the benefits and why you may want to join a consortium. Next slide, please. Okay, let's dive into the benefits. Why might this model work for you? As a member LEA or as the lead LEA, you may inhabit either role depending on. So having a lead LEA gives you the opportunity for really specialized expertise to increase efficiency and effectiveness. What I mean by this is really the value of having a staff member with the ability to dedicate a large or larger portion of their time to learning and mastering the details of the program. Additionally, having a group of LEAs to work with and brainstorm also fosters a really strong base of program knowledge. To that point, having a lead LEA taking on a bigger role or a bigger full-time equivalent, FTE, can increase the efficiency by each member LEA not having to do every single aspect of the program individually, and reducing individual workload for member LEAs. For example, and of course, this will vary by circumstance, but if you have 6 LEAs that average 40% FTE to each run this program, with a consortium model, one LEA might have 100% FTE, and the other 5 might be able to reduce their time to 10% or 20%. We never want the member LEAs to lose their individual expertise or knowledge and have that be zero, but there can really be some savings at each LEA's staff time. Excuse me. Both of those points, the specialized expertise and reduction in staff time, leads me to the last point here, which is maximizing the opportunity and benefits for small and or rural LEAs. Each LEA will not need to know every possible detail or billing opportunity, nor will each LEA need to reinvent the wheel every year. Collectively, with a central lead LEA, the time and energy can be optimized to supporting all billing opportunities. Next slide, please. Those are some of the benefits, but before I can keep going, we also need to make sure we clear up these requirements. When we think about the graphic before about the lead LEA working with DHCS and the member LEAs working together, this is what we made. So there will be one national provider identifier, or NPI, used for claiming, which would be the lead LEA. There will be one CRCS, which is submitted annually. There will be one annual report for the whole consortium, and all member LEAs will need to be in one random moment time survey universe. So one example where this isn't a limitation and the consortium will have no issues at all is a COE runs a consortium for some of their districts in the county. All LEAs in that county are in the same RMTS region. A second example where this may be an issue and might prevent a consortium is, for example, many charter schools are run by charter management organizations and have school sites across the state, for example, in the Bay Area and in Los Angeles. In this case, those sites can't be in one consortium together because they would be in two or more different RMTS regions. So we're dropping a link in the chat to the LEC service regions, which are the RMTS regions. It should be noted that the program requirements like documentation are, of course, everyone's responsibilities. That covered the major requirements, but now we're going to talk about the responsibilities for each group in a little bit more detail. Next slide, please. The responsibilities you see on the slide are for both the lead LEA and the member LEAs. Looking at the lead LEA, so remember we have submit those administrative documents we covered on previous slides, like the CRCS and the annual report, including enrolling in LEA BOP initially if they're not already enrolled. There's also a tri-party data use agreement, or DUA, which can be found by emailing DHCS. The email is lea.annualreport@dhcs.ca.gov. The lead LEA submits the billing for all member LEAs under that lead LEA's NPI. That's the NPI that will be attached to all interim claims sent to DHCS for payment. This also means that audits are the responsibility of the lead LEA. It's their CRCS, so they will be expected to have all the necessary documentation that goes into it. Then for the member LEAs, they will have to assign their reimbursement to the lead LEA and make sure not to use their own NPI to submit claims separately if they have one. They will need to designate a point person to liaison with the lead LEA regarding things like cost, documentation, updating the practitioners list. As mentioned before, the staff time requirement should be less, but it's still best practice to have that liaison or point person. And then you will need to enroll in RMTS, which means coordinating with your LEC, as described on the previous slide. Contact your LEC, also using the following link. We'll put that in again. Next slide, please. Beyond the requirements mentioned in the last slide, how you set up and run your consortium is largely up to you, which is where the responsibilities to be determined at the LEA level come in. We split up some pretty clear duties on that previous slide, and a lot of this is still decided at the LEA level. For example, documenting services. All practitioners will need to document services provided to students, but in a consortium, who's responsible for supporting service documentation? Does the lead LEA provide training to practitioners at the member LEAs, or do all member LEAs use and access the same electronic health record system? Are the lead or member LEAs responsible for conducting quality assurances? So speaking of quality assurance checks, or sometimes called self-audits, is there a central person at the lead LEA that'll run the service reports, review service documentation to see if it meets audit standards, or will the member LEAs have their own at the LEA level? So also creating TSP list and managing the RMTS. There's a lot that goes into that. So all staff that intends to bill and be a part of the program will need to be on the TSP list. Does it make more sense for member LEAs to supply that list, or to have the lead LEA run the HR reports and create that list for them? This can be a combination of both. Then there's managing your moments. Who do you want doing the follow-up with your staff that doesn't respond to the moments on time? Each member LEA has their own RMTS contract, but they're still ultimately accountable for the TSP list. So although the lead can support them with this process, there's still something they need to manage. So another topic to discuss and decide responsibilities is pulling financial information for the cost reports. Member LEAs will need to provide their actual cost of delivering services to students, such as contracts and practitioner salaries and benefits, for example. So you'll need to provide that to the lead LEA, and all consortium members' cost reports will be included in one CRCS. So is it the responsibility of the lead LEA to pull those reports or the member LEAs? If a consortium decides to work with a billing vendor, who holds that contract? Is it a central contract or several individual ones? Distribution of funds back to participating LEAs. What method is used? When are reimbursement funds distributed back to member LEAs, and who runs that process? All of these responsibilities should be clearly outlined in an MOU or cooperating agreement between all parties. A lot of things to decide. Next slide, please. We've covered both the set of requirements for a consortium and other responsibilities that should be negotiated between consortium members and lead LEAs. And now I want to go over just some considerations or possible challenges to remember. So, for example, when we look at the data sharing for financials, if LEAs have separate financial systems, each LEA will need to pull that data individually to be combined into a single RMTS. Do you have the financial structures to be able to do that? Practitioner information, salaries, benefits, work schedule reports, all need to be shared between the member LEA and lead LEAs while maintaining security of the data, because it does contain personally identifiable information. Student information is also shared. Some central place for documenting services and claiming for services must be determined that will ensure that protected health information is secure. Do you have the ability to transfer that information between LEAs? Then there's also the MER calculation. As a reminder, MER stands for Medi-Cal Eligibility Ratio and is simply the percentage of students that are enrolled in Medi-Cal. For this program, the MER is part of the cost settlement equation, because ultimately this program seeks to only pay for eligible students. In a consortium, all participating LEAs combine their MER. Let's illustrate the impact of this with an example on the next slide, please. In this example, I'm going to work through the example math and how a weighted MER calculation for the consortium. In this example, we have one lead LEA and two member LEAs. And to keep the math simple, all LEAs have a total student population of 100 each, which of course in the real world is very unlikely. Of the 100 students enrolled at the lead LEA, 80 are Medi-Cal enrolled. So the MER is 80%. Member LEA A has 60 Medi-Cal enrolled students out of 100 total students, so their individual MER is 60%. And member LEA B, Medi-Cal enrolled students, they have 30 Medi-Cal enrolled students out of 100, so their MER is 30%. Based on the requirements of this program and the requirements of a consortium, we'll be combining the MERs for this consortium, which would end up with 80 plus 60 plus 30 Medi-Cal students divided by the 300 total student population. This gives us a combined and final MER of 57% for the entire consortium. So this means participating in a consortium gives you this new combined MER for your consortium's cost report. So now we ask, how would that compare to each LEA completing their CRCS separately if they were not in a consortium? For the lead LEA, this consortium actually decreases their MER, so could decrease the cost reimbursement they would receive compared to participating individually. For LEA A, the impact is minimal. The individual MER and the consortium are very close. For LEA B, the consortium increases their MER, so actually could increase their cost reimbursement they'd receive compared to participating individually. When looking at creating a consortium, this impact is minimized if the LEAs participating in a consortium have similar percentages of students enrolled in Medi-Cal. This is just another example of something you might want to consider going into this. Next slide, please. Okay, let me introduce Debbie Connor from Mendocino COE to dig into a real world example of what this can look like.
Thank you, Jeremy. In Mendocino County, we have 14 member LEAs in our LEA Bob consortium. We hold the contract with our billing vendor. We collect weekly interim payments from DHCS, and our interim payments are made payable out to each LEA after the end of that fiscal year. This annual distribution of payments allows for us to complete the final funding research of direct service providers to be verified to make sure we're paying the district or LEA that actually paid for the cost of the service. Because our final settlement audits have historically had a trend of about 10 to 15% withhold, we do reserve 15% of the annual interim payments that we make to our consortium members to cover that trend of audit findings that are determined later. As the withholds occur, we book them against those reserved funds so that we never ask LEAs to repay any funds to us to cover those withholds. How we started this process was back in 1996, our SELPA agreed that LEA BOP is necessary to support student health service costs. Our SELPA contributes funds to pay for the 60% of an FTE to provide LEAs with centralized billing experts to facilitate compliance measures, reporting requirements, training district providers. We develop program policies and advocate for our students' health services. Next slide. Some of the benefits that we've realized through this model are that we have the centralized compliance work being done by our COE on behalf of all LEAs. The data use agreement, the annual report, the CRCS, all audit documentation. LEAs in our county often share practitioners to meet the needs of the students county-wide. We do this as a contract with the LEAs, which allows them to seek reimbursements for their allowable costs. Billing vendor costs are shared by a % of reimbursements earned. This reduces program management costs for each LEA and allows for our small and rural LEAs to participate without the costs of administrating the LEA BOP exceeding potential reimbursements. Next slide. Some of the lessons we've learned through this model are that we must have really strong connections with all district staff and contracted service providers. We need to have systems in place and processes that are transparent and inclusive of each LEA's needs, and continual collaboration with LEAs, SELPA, and state agencies are the key to the program's success. And now I will hand it back over to Lisa.
Wow, I really appreciate you, Debbie, for illustrating perfectly some of the concepts we've discussed already today. I know there's been lots of questions that are coming in. So we are excited to get to some of those questions for you as well. Before we get to questions, we have a poll with some quiz questions. We will be getting to your questions shortly, as I just mentioned. So please make sure you drop your questions in the chat. Before we move into answering questions, we're gonna please take a couple moments to answer the quiz questions that will pop up as a poll. And these are here to help us gauge the usefulness of this workshop. So we will leave this poll open for a couple of minutes to allow you a chance to respond. So the questions are that come up as the poll: 1, what is a billing consortium? 2, what is not a major component of LEA BOP administration? And 3, what is one requirement for a billing consortium? So we're going to give folks a couple minutes to respond to those questions. Please take a moment to select the correct answers in the poll.
Participants complete the quiz.
So thank you so much for responding to those quiz questions. We will review the correct answers in the next slides. So for question number 1, what is a billing consortium? It looks like 59% of you got the answer correct. Correct, with most everyone else having not responded with an answer, but 59% of you got the answer correct. The correct answer was B, a group of LEAs that bill under one MPI. So we covered this previously, but a reminder that the requirements of a billing consortium is a group of LEAs that submit under one MPI, submit one CRCS, submit one annual report, and are all in the same RMTS region. All right, so the next slide. So for question number 2, what is not a major component of LEA BOP administration? It looks like 40% of you got the answer correct. Out of everyone participating, 35% didn't respond. So 40% got the answer correct. The correct answer was C, selecting a billing vendor. As a reminder for everyone that working with a billing vendor is not actually a requirement of this program, but the 2 other answers, completing the CRCS and updating the TSP list, both are administrative responsibilities. And a lead LEA in a billing consortium can support member LEAs by submitting the CRCS and can help LEAs with updating the TSP list. And if the consortium opts to work with a billing vendor, the lead LEA can play, but is not required to play, a role in selecting and managing a billing vendor. Next slide. And so for question 3, what is one requirement for a billing consortium? It looks like 54% of you got the answer correct, with 37% not responding to the question. But the correct answer was A, submitting one CRCS for all participating LEAs. So this is super similar to the first poll question, which is what are the requirements for a billing consortium? And again, those are one MPI, one CRCS, one annual report, and all members LEAs in the same RMTS region. The other 2 answers for this question are not requirements of a billing consortium. All right, thank you so much for answering those quiz questions. We're going to move on to the next slide, which will get us to our Q&A. So first, we will respond to questions that we received through the registration form. And then if we have time, we will get to a lot of those really great questions that have come in through the chat. So again, we've been monitoring the chat, and we'll try to respond to as many questions as we can. But please note that if we don't get to your question, if we don't have any time to answer all of them, we will respond to all the questions via email after the training. Next slide. So first, we will respond to questions we received through registration, and I welcome my colleague Lydia to join me and Jeremy in answering some of those questions. So first, we received a lot of general questions about LEA BOP, such as what services are covered, how an LEA should enroll, and how LEAs can get started. So I just want to mention really quickly that digging into all those questions is really beyond the scope of today's webinar, which is focused on how to start and participate in a billing consortium. But Lydia, can you maybe jump in and before we move on to consortium questions, offer some brief suggestions for where folks can find the answer to how to get started
Yeah,
generally
absolutely.
in the program.
Absolutely. So, like Lisa said, we've been getting a lot of really good questions about how to get started in the program. And in short, there are three main things you need to do to get started. One, you need to sign up for a National Provider Identification or NPI number. You need to reach out to your LEC to set up a random moment time survey or RMTS contract and start date. And third, you need to start the enrollment paperwork. And we have several very helpful resources and past workshops that provide introductory and enrollment information that we highly recommend you review for more details. And I will be dropping a link in the chat for each of these resources, including the two introduction webinars hosted in March and April of 2023, an introduction to LEA BOP and relaunching your LEA BOP, understanding the program and strategies for success. And both of these has slide decks and also the recordings of these videos on our training website. We also have an enrollment timeline available on our website to help navigate through this process. And if you look over through all of these resources and you would love some one-on-one discussions about this topic or any enrollment items you have further questions on, please feel free to fill out a technical assistance form. I will also drop that in the chat, and then send that to the LEA inbox, and we'll be happy to set up a meeting with you. So now I'll just drop all those resources in the chat for you so you can take a look at them as we go on.
Great. Thanks so much. So now we'll get to the two registration questions we received about Billing Consortium. So the first question is, what are the requirements for a consortium and who can be members of the consortium? So I'm going to invite my colleague, Debbie. Would you like to answer this question and get us started?
Sure, thank you. So in Mendocino County, it was our SELPA Policy Council that determined that all LEAs in our county can participate in the consortium, including charter schools. Our SELPA Policy Council voted to use part of their off-the-top special education budget to cover the FTE cost of consortium administration on behalf of our LEAs. The local level considerations to join a consortium could be different for each LEA, depending on who the lead agency is, how the cost of the consortium will be supported, and how much LEA support is available from staff. And then Lisa can refer us back to the requirements of the program that Lydia had listed in the chat.
Yeah, and I would just also reiterate the requirements for a consortium, which we've walked through previously in this webinar, are again, one NPI for the entire consortium, one CRCS is submitted, one annual report, and all member LEAs and the lead LEA need to be in the same RMTS region. So again, those are the requirements. Excuse me. The second question we received through registration is, how do we join a consortium and what does this look like in a small district and communication with our staff? So Debbie, welcome you again to join us in answering that question.
Sure, thank you. Again, in Mendocino County, our lead entity administering the consortium made this decision in collaboration with superintendents, LEA business officials, and in compliance with our RMTS LEC and DHCS programs. Each LEA must assign a contact person to help coordinate the SMA and LEA BOP program compliance at the LEA level. The consortium administrator, our COE, will communicate with each LEA contact person, their program staff, and even contracted providers to ensure program training, compliance, and technical assistance needs are met.
Great, thank you so much. All right, we're gonna move to the next slide and get to your everyone's questions that have come in via the chat. So the first question we received through the chat, which Debbie, I'm gonna turn to you to answer. do you have any suggestions on developing and running the local collaborative that is there to make decisions on the reinvestment of funds received through this program? So do you have any suggestions, Debbie, on running that local collaborative when you are participating in LEA BOP through a billing consortium?
Sure. So what we do in our county is we have each of our LEAs fill out their own local annual report. We actually compile all the documentation, all the information for them. We list all of our LEA Billing Consortium members on that annual report, and we send that out to each LEA for them to be able to determine their own reinvestment needs of their share of those Medi-Cal reimbursements. And what we do as well is then we bring all 14 of those annual report reinvestment documents back into our SELPA Policy Council and SELPA Steering Committee. And we collaborate as a group with all LEA special ed directors at the table to determine our one annual report reinvestment answers. And pretty much we all agree, because of our tight SELPA network and our steering committee groups, it's very easy to agree how to meet the needs of each district, but we do make sure that each district has the opportunity to align their reinvestment needs to what best suits their own students.
Thank you so much. All right, I'm going to move us to the next chat question, which I welcome Lydia to jump in and answer. So the question is, do I understand correctly that the consortium affiliation is a requirement for ESMA, even if our LEAs are even if our LEA or LEAs are planning to work independently for LEA BOP purposes, billing and documentation? Lydia?
Yeah, sure. So the answer to that is the consortia affiliation is actually not a requirement for the school-based Medi-Cal administrative activities, or ESMA program. But for any further questions regarding ESMA program, please email esma@dhcs.ca.gov. I'll actually drop their email in the chat. They'll be happy to give any clarifications on the ESMA program that you might need.
And in case it's helpful, I wanted to just really quickly clarify, because we said consortium twice to mean two different things. So today's workshop is talking about a billing consortium, so working together with multiple LEAs to participate in the LEA Billing Option Program. But there also are local education consortium, or LECs, which are which you do have to contract with to participate in LEA BOP, but those mean two different things, if that is helpful. They're LECs, and today's workshop is talking about a billing consortium. All right, we are going to move on to our next chat question, which are the member LEAs required to have an MPI when working within a consortium? So again, turning to you, Lydia, to answer that question.
So the answer to that is it is not required, since the lead LEA's NPI is the NPI that is identified with DHCS and used for billing for all claims associated with the consortia.
Thank you, Lydia.
Sure.
Next question is there a limit on how many LEAs can participate in one billing consortium?
DHCS does not have a limitation on the number of LEAs that can participate in the consortium.
Great. So the answer is no.
Short and sweet.
All right, next question. How will LEAs in a consortium know the amount of funds they generated individually? And so Debbie or Jeremy, if one of you want to jump off to answer. I think Debbie, you explained a little bit earlier in your response to the first question how you look at the redistribution of funds, but if you can give any insight to how your consortium knows how much funds are generated by LEAs participating.
Sure. In our county, because our districts share so many service providers, and they may be employed by the COE, or they may be employed or contracted with one of our larger LEAs, because those providers are shared across the county to serve the students, That's one reason we do not distribute the interim reimbursements until the end of the year. We do payroll reports, we do accounts payable reports, we look at contracts. We make sure that we know who paid for the provider, because they may be my COE employee, but I have an MOU where we are doing a fee for service charge out to the LEAs who use our service providers. So in the end, they're reimbursing us the salary and benefit costs, so that LEA gets the reimbursement generated by that provider. So we use our SACE IEP system and our third-party billing module within there to run reports on what child was served, what school they went to. We look at who paid the provider through payroll or AP. We do a lot of cross-reference checks. We combine the RADs from the whole entire year into an Excel document. And then we start sorting by who paid the provider, and that's the LEA that gets the reimbursements.
Great, thank you. I want to just really quickly add on to that answer, Debbie. That also, to just reiterate what we talked about at the start of this webinar, is to make sure that we're understanding that revenue received through the program is sort of two parts. So LEAs generate interim claims for services provided, but then also ultimately receive funding through the final settlement that is determined through the cost report. So I just want to reiterate that there are sort of two ways to track how services and the cost of services are delivered. I think we have time.
Sorry.
Oh, Jeremy wants to add to that. Yes.
Yeah, can I just add
Jeremy.
to that? Like, so Debbie's method is what they do. And when you're designing this, you can do it any way you want. So whatever works for you. You could split it up based on student population. You could split it up based on literally how much cost each person puts in, and then create a percentage that way. It's really just math, and it's about making every member LEA comfortable with that like equation. And you see Debbie's method is very methodical. So there is no limit. But thank you for that example.
Great. I think we have time for two more questions. So I'm going to jump us around a little bit. So Lydia, Debbie, and Jeremy, hope you can move with me. But the next question I want to bring up from the chat is, what is the difference between a consortium versus using a billing vendor? And so Lydia, I'm going to turn to you to answer that question.
Sure thing. So an LEA may choose to use a billing vendor that will provide a variety of services that may include providing an electronic health record system, submitting claims for interim reimbursement, running the Medi-Cal eligibility ratio, and submitting the cost and reimbursement comparison schedule. And a consortium is a group of LEAs that are billing under one LEA's NPI and submitting one CRCS. Similar to working with a billing vendor, the lead NPI is a consortium. In a consortium, may take all the responsibilities of the above services and may even do that through a billing vendor.
Great, thank you. Okay, so I think this is our last question, which is a question for Debbie. What is a typical contract that exists between the lead LEA and the member LEA in a billing consortium? Is there any sample or standard language that can be shared? And I just want to note that I'm going to ask Debbie to sort of give her insight in Mendocino County, but please note that this is really something that is decided between LEAs that are part of consortium and their legal teams, and the DHCS does not get involved in providing contracts for consortia or providing sample language. But Debbie, I don't know if you want to offer some insight into how this works in Mendocino.
Sure. So first off, we had it, it's part of our SELPA Policy Council local area plan. And then on top of that, we have MOUs with each of our LEAs that indicate the types of things that we need to rely on them for. They need to help us make sure that their providers meet our training and compliance levels. They have to be available for the self-audits that we do. The LEAs have to provide, if we're not able to get, they have to provide contracts for salary and benefit employees, as well as accounts payable, consultants, contractors, hired out service providers. And so we list everything out. We indicate that they are part of RMTS and that they run their TSP lists through us, so that we're making sure the TSPs are on the right list of their RMTS programs to make sure that they're billable providers in ours. We list in there that we review all of the credentials and or licenses to make sure the providers are coded correctly in the third-party billing system and that they are appropriate to bill to DHCS. So we have a lot of items in there that the LEAs are responsible for supporting, so that we aren't just scrambling at the local levels and intruding upon staff who don't know who I am or don't know who our staff here at the COE are. So we make ourselves very integrated in their systems. And then we show them also in that MOU what we are responsible for as far as the CRCS, the MPI number, the third-party billing vendor contract, the distribution of reimbursements, the squaring up of those final payments that come in, and as well as any audit withholds. So it's pretty descriptive, and yet there's still room for growth in that, just depending on what each LEA or lead agency has a need for. So I think, like Lisa mentioned, it's not something that we could put in concrete, but there are a lot of options out there.
Great, thank you so much. I know that we didn't get to everyone's chat questions. Lots of really great questions coming in. Really appreciate you sending in those great questions. And as a reminder, we're keeping track of everyone's questions. Any question that we did not answer will be responded to in writing. So next slide, please. And with that brings us to our next steps and closing for today's workshop. Next slide. So we've shared a lot of resources that in the chat today that are specific to how you can start and participate in a billing consortium. We'll send those resources out in an email after today's webinar. But on the slide, there are other resources that are here to support your LEA in all other aspects of administering the LEA BOP. So we encourage you to all to spend time on the LEA BOP website and reach out to DHCS for any questions that you have through the LEA inbox. So DHCS hosts quarterly stakeholder meetings. Information is available online from past meetings, and we're dropping a link into the chat where you can get information on those meetings. And the best way to know about them is to sign up for DHCS's email subscription list, which we are also dropping a link to in the chat. And as mentioned a couple times already, if we encourage you to sign up for technical assistance with DHCS if you have particular questions. And so we're also including a link to where you can sign up for those TA requests in the chat as well. Next slide. We also have one more workshop as part of this outreach effort coming your way. So next month on February 15th, we will have a workshop for new LEA BOP billing coordinators. So many of you that are responsible for this program at your LEA. So hope you'll join us for that training. And finally, DHCS is hosting 2 office hour sessions in March and April. These are opportunities where you can come and ask questions about the program, and we're hosting 2 for topic specific office hours. So in March on the 13th, March 13th, we're doing an office hour geared towards small and or rural LEAs. And then our office hour on April 22nd will be geared towards questions about today's workshop around a billing consortium. So registration for both the workshops and office hours will be opening shortly, and we will reach out to everyone through email with registration information. Next slide. And with that, we want to thank you so much for participating in today's workshop. We hope you enjoyed it and learned something today. Thank you again, everyone, for joining us bright and early on a Tuesday after a 3-day weekend. Thank you so much, and we look forward to seeing you at a next workshop or office hour soon.